Okay, now we are recording. Again, this is Dr. Marc Weigensberg talking on mind-body approaches to diabetes management on March 20th, 2015. And if you want to make sure you can see by the camera there.
And is that being projected?
Yeah, that's being projected.
Oh, okay. You know what? Maybe I'll move it up even to the very top corner. Can we do that?
Yeah,
or is that?
Yeah, I think so.
Yeah.
There you go.
Just so that it's right. Because I don't know what it'll do with other slides. Hopefully they'll be visible. All right. Take two. I guess it's kind of appropriate given the topic of mind-body that a few, half the audience here and half is out there in cyberspace, so in virtual reality, so to speak. So we'll see how this goes. I want to thank you again, Dr. Friedman, for inviting me. It's really good to be down here at King Drew. It's been many, many years since I've been down here, and there've been a lot of changes, so it's really good to be here. See if I can get this to advance.
Yeah.
Should.
What's on the white box? And then you should be able to click from there.
Oh, okay. Thank you. I have no personal conflicts to disclose. Yeah, there it's working. These are the objectives as they appeared on your CME form. If you're here at King Drew, I don't know if the other group did, but basically I'll be discussing the relationship between stress response and glycemic control in diabetes. Hopefully by the end of this talk, we'll recognize the benefits of some mind-body interventions that I'll be presenting some of the newly developing evidence base for. And then towards the end, I'll be talking about a topic that's brand new and near and dear to my heart, is an area called narrative medicine, or actually the role of the patient's story in promoting healing within the world of diabetes. So hopefully we'll be in for a good session together today. So I'm making sure that you can see Professor Einstein's quote here. One of the obviously preeminent scientists of the 20th century and arguably one of the most knowledgeable men in the world said that imagination is more important than knowledge. And I always loved that quote, and then recently found the full quote, which you can read down there below, which I love even more because it expands on just the one-liner. And if you are not aware that not only was Albert Einstein a great physicist and a Nobel Prize winner, but a great philosopher, and if you ever want to read some of his quotes, they're really quite remarkable. Just Google him. It's pretty cool. All right. So, we lost it again. Did I click something?
I'm not sure. And then go down to there. Yep.
All right. Okay, I want to set the stage for integrative approaches to diabetes by talking first about the concept of integrative medicine, what formerly has been called alternative medicine, then it evolved to complementary medicine, and the kind of PC catchphrase now is integrative medicine. And what does this mean and what are definitions? And I kind of think of two definitions for integrative medicine. The first one is conventional allopathic Western-based medicine plus what has been called CAM, or complementary alternative medicine. So it's really combining those two modalities of medicine into care. And the CAM modalities include mind-body practices, which we'll be discussing today, can include herbal approaches or nutritional supplements, and then body-based modalities such as massage, chiropractic, these sorts of things. So that's represented here in this picture of the caduceus, which is the staff of the Greek god Hermes with the two snakes. I think of it as one snake being conventional medicine, one snake being complementary alternative, and both of them climbing up the healing staff. Okay.
I'm not sure. Just put away the bottom.
Okay. Thank you. So that's one potential diagnosis. Definition. There's another, which I actually prefer, which is a more integrated definition, if you would, of integrative medicine, which is really a philosophical approach towards the whole person, often spoken in terms of body, mind, and spirit. So it's a medicine that does not separate out physical medicine from other aspects of the human being. And this is represented most obviously in whole systems of medicine, such as traditional Chinese medicine, Ayurveda, indigenous systems, and others. But I think when we think about Western medicine, we can come up with a concept that represents integrative medicine as well, which is the conjunctive use of CAM modalities with allopathic treatment. So in other words, rather than switching over to alternative or complementary approaches when Western medicine doesn't work, it really actually can use both right from the get-go in approaching the patient in a really integrated way. And I think of the single snake climbing up the staff in this way, and this is the staff of Asclepius, the great Greek physician of antiquity, and also in the Hebrew Bible, there's a story of Moses putting the copper serpent on the top of the staff, and this led to the healing of the Israelites when they were in the Sinai Desert, which I think in maybe the first recorded instance in Western literature of how guided imagery can lead to healing. So what are the principles of integrative diabetes management? And this flows from the definition of integrative medicine that I just spoke about. And these are just some of the things I think to highlight and to think about as we go into the specifics of mind-body approaches. So number one is attention to the whole person. So the person with diabetes is more than their insulin and more than their blood glucose results, right? It's a collaborative care model. So rather than expert dictating to patient what really is needed, think of the provider, the physician, as the expert in the disease of diabetes, whereas the patient is the expert in their illness of diabetes, meaning not only the disease process, but the patient's experience of that disease within their whole life and their whole being. There's also an emphasis on healing rather than cure when you come at things from an integrative perspective. And what is the difference is rather than being a war between the disease where you're seeking an absolute cure, war on diabetes, war on cancer, which are often kind of phrases you'll hear in conventional Western medicine. Think of healing as any movement towards a wholeness or a balance in the person. The word heal actually comes from the root word linguistically meaning whole. So to be made whole, be moving into balance and harmony in mind, body, and spirit is really what is being sought in an integrative approach. And of course it uses integrative modalities such as mind-body, which we'll be talking about, perhaps herbs, which I won't talk about today. It's another whole topic. But for instance, the Nopalus cactus, there's evidence that that may help with glycemic control and things like that. So what is the rationale for even trying mind-body approaches to diabetes? Well, we know that, I'm sorry? There's too much to think about in delivering a webinar. All right, so the rationale for approaching diabetes with a mind-body approach, we've known for a long time that it's very difficult to control diabetes in somebody who really has a life situation consisting of a significant psychosocial disturbance. So, for instance, we see poor glucose control, we see recurrent DKA. From my profession as a pediatric endocrinologist, in those families that are really dysfunctional or where parents are really not very good at their parenting skills, these kids really suffer, and it's virtually impossible to achieve good glycemic control in that circumstance. So you have to address the mind, the body, and the whole person. Psychiatric disorders are known to be of increased frequency in both adults and pediatrics with diabetes. So there obviously is a mind-body link, and those with psychiatric disorders, particularly depression, I think any of us as physicians know that it's very hard to achieve glycemic control in somebody who's clinically depressed. And finally, I'm going to talk quite a bit now about the role of the stress system, both directly and indirectly, affecting both risk for diabetes in patients who may have other risk factors and in control of diabetes if somebody already does have overt diabetes. So the stress response system seen here is well known that when we're confronted with an acute stressor, our body goes into fight or flight mode, right? And this is regulated by two systems from the hypothalamus, the hypothalamic pituitary adrenal gland axis, stimulating cortisol secretion as one of the quote-unquote stress hormones in the body from the adrenal cortex. And cortisol provides increase in blood glucose through gluconeogenesis. and other factors that help us in our fight or flight response. On the other hand, also when we're confronted with an acute stressor, then the autonomic nervous system kicks in. And similarly through the adrenal medulla, for instance, secreting additional epinephrine. And this also promotes glucose delivery from the liver, hepatic glucose production into the bloodstream to mobilize our energy systems to either fight or flight. And this works in the short term. This is really good. If you're confronted with a jaguar in the middle of the jungle and you got to move, either fight or flight, you want this system to be happening. But the problem is, if in our current age where we're all under such chronic stress, for instance, when you have to give a webinar and you don't know where the camera is or where the microphone is, you know, keep getting down here on the freeway from, you know, from East LA to South LA. Yeah, my cortisol, you don't want to know I don't want to know my cortisol right now. But and we're always under these chronic stressors, and this leads to chronic disease risk. And in the realm of diabetes, of course, these hormonal responses can lead to increased blood glucose, blood pressure, and in the pre-diabetic state, it's been shown that chronic stress and hypercortisolism from that can lead to emotional eaters, and particularly to eat more emotionally, and therefore increase excess and body fat and promote insulin resistance and risk for type 2 diabetes. There's a lot of evidence on this in adults, and we're developing quite a bit of evidence of this in adolescents in the Latino population here in our research studies at USC. Now, stress has long been linked to poor control in type 1 diabetes, that these chronic stressors tend to lead to high blood sugars. I think all of us who manage adolescents or kids or adults with type 1 diabetes and our patients tend to be on the quote-unquote emotionally stressful spectrum, be more quote-unquote brittle with their glycemic control. And stress may have both direct effects on blood glucose, which I just alluded to through the hormonal responses, and also may lead to poor diabetes self-care behaviors and infrequent glucose testing, perhaps insulin omission, and this can lead to bad glycemic control. So either directly or indirectly, stress can lead to poor control in type 1 diabetes, and we have shown in a study in young adults that these relationships hold. This was a recent publication from Beth Piatek and our group, showing that the more absolute-like stressors young adults with type 1 experience, the higher their A1C, and if they perceive their lives to be more stressful by measuring actually perception of their stress, that was also correlated with higher A1C. Oops, and we're out of the talking now. There we go. So let's move into some of the mind-body therapies for which there is an evidence-based developing to use in diabetes, and there are a lot of them listed here. I'm going to focus on these top four, guided imagery, because that's actually what I use in my patients and my research. Also relaxation practices, mindfulness-based practices. There have been over 500 articles now on the effectiveness of mindfulness in a variety of chronic disease states. So I'll talk about the evidence base that's developing for mindfulness-based practices in diabetes, and then a few slides on an increasing literature on the use of yoga in diabetes. Oh, and this little kitty cat's totally relaxed after going through his mind-body exercise. So I mentioned guided imagery. So what is guided imagery? It's a CAM modality, complementary alternative mind-body modality, which is essentially a facilitated meditation. So as you see in the slide, there's a facilitator on the left who's guiding this young man through a nice imaginary journey that includes a beautiful beach scene and a sunset, and he's very relaxed, as you can see. So it basically is facilitating this meditation and the generation of mental images in order to achieve a specific health outcome. And in our studies, we used it to reduce stress hormone levels and improve health behaviors. And it's ridiculous to talk about guided imagery. It's very good to experience it. So I'm going to offer you a little experiential exercise here for 2 or 3 minutes. And you who are tuning in on your computer screens can do this as well. basically all I'll do is invite everyone to close their eyes, although you don't have to. If you're not comfortable with that, you can just kind of let your focus dim as you look straight ahead. And following my voice, I'll just guide you through focused attention to the breathing first, and then we'll invite an image to form in our minds that represents a place that is just comfortable and relaxing for us. And then just over a minute or so, we'll explore that comfortable, relaxing place. Now, some of you who have done this sort of thing before may already be there, and if so, you can just stay there and observe what happens. But the rest of you, I invite you to close your eyes or let your focus dim, and let all thoughts go out of your head and just focus on your breathing for a moment, so that you're breathing in and breathing out, just noticing how your chest rises and falls with each breath. Inhaling and exhaling, thinking of no other things that you need for right now. Just focusing on this breathing, which we do 12 to 20 times a minute without even thinking about it. But what the data shows is that when you think about it and really focus on it like this, even this can start to really relax your body. You may be already experiencing that just through this simple breath. Notice the temperature of the air as you breathe in. It's kind of cool and refreshing. And as you breathe out, it's a little warmer, as if it's taking away any stress or tension from your body. So just allowing this attention to your breath to really relax you. You might notice now how you're a little bit more relaxed than you were a few breaths before. And if thoughts intrude, because our minds are always racing, that's okay. Just kind of notice the thought that comes in and interrupts your breath, your attention to your breath. And without judgment, just kind of notice it. And with the next out breath, you can let it go, because you don't need to remain attached to that thought for the next few moments as you return to your breath. Breathing in and breathing out. Just noticing how your body may have already achieved a little gentle state of relaxation at this point compared to before. And now in the next breath or two, invite an image to form in your mind that represents a place where you feel just comfortable, relaxed, calm. It may be a place from your real life where you do feel these feelings, or it may be something entirely out of your imagination right now. Just be open to whatever image forms. And if the image has come, just stay with it and observe it, see what's there. And if the image isn't coming, that's okay. Just stay with your breath, be open to an image to come, and sometimes it's just the breath is the image, and you can stay with that. But if the image is there, take a look and see what's there. Are there other objects there, or people? Are you in the image? If you are in the image, just notice the position of your body. What are you doing? You might notice other things in the image, colors or scenes, or perhaps the quality of light might tell you what time of day it is. Is it daytime? Is it nighttime? Just noticing and observing as you continue your gentle relaxation breathing and observing this image. Notice if there are any sounds associated with the image, or any smells or aromas. Now notice the feeling state in your body, just how you feel in this place that represents just comfort and relaxation. Notice any sense of relaxation, calm, freedom from stress. And over the next couple breaths without my voice, just allow yourself to feel that relaxation and calm. Now over the next couple breaths, you can let the image gradually fade, knowing that you can come back to this anytime you want, just by closing your eyes and breathing a little bit, and inviting the image back and exploring it in this way. Give yourself a little vacation in this way from your usual daily grind, and begin to come back to the present time. Notice how you feel in the chair. And when you're ready, take a big cleansing breath. Gently open your eyes when you're ready, and we'll continue on with this grand rounds. All right, everyone's back from their little trip. Just a quick show of hands, how many feel they experienced a little bit of relaxation in that exercise compared to before they started it? Okay, almost everyone, if not everyone. All right. It's kind of nice, right? When you're at your desk, just close your eyes for 2 minutes. When all the pages are driving you crazy or the phone calls, So I want to show you a little data from a study we did at USC here. This is in obese Latino adolescents. So these young people did not have diabetes yet, but many of them had prediabetes or metabolic syndrome. And this is a study sponsored by the NIH, a pilot study, National Center for Complementary Alternative Medicine, or NCAM. They've actually changed their name now to the National Center for Complementary Integrative Health. But I'll still call them NCAM because that's what's on the slides. Anyway, about 30 kids randomized into 2 groups, about 15 each. The intervention group received a lifestyle education consisting of learning how to eat, didactic education about healthy eating and physical activity, how to improve their healthy lifestyle habits, right? And they received 12 weekly sessions of interactive guided imagery, similar to what you guys just experienced, stress reduction guided imagery, and also imagery that was actually directed to motivate behavior change. I won't go into the details of that. It takes too long to kind of explain that, but suffice it to say that I feel that guided imagery is a really nice way to internally motivate behavior change. And we have some data to support that, which I'll show you in a minute. The control group received the same didactic 12 weekly sessions of lifestyle education, and then they got to play with computers and create a digital story using photographs and videos. So they got really just to control for contact time with staff. So both groups were getting the same kind of attention. But they did not get health-directed guided imagery. And I'll show you results from the study on acute stress reduction based on cortisol levels and then on physical activity changes. So this slide shows acute changes in salivary cortisol, shown on the y-axis, from baseline to the end of the session. These were 45-minute guided imagery sessions. So they did basically what you guys just experienced, but for about 15 to 20 minutes of a total 45-minute session. We talk a little bit ahead of time, then we go through the imagery, the stress reduction imagery, and then talk a little bit afterwards about how their experience was. The whole time was 45 minutes. So 3 sessions, session 1, 2, and 3 shown on the x-axis. And in each of the 3 sessions, you see here the change from baseline. So if baseline is set at 0, whatever their salivary cortisol was, you see a reduction in salivary cortisol in the group that got imagery in the black bars versus the control group in the open bars. And the average reduction in salivary cortisol acutely was about 40%, about 38% in each of the 3 sessions. So this was acute change. This was acute change. So yes. Time of day? This was done in the afternoon. So probably around 5 o'clock in the after school. So between 4:30 and 6 p.m. It was not accounted for by circadian rhythm. The control group was done at the same time, and their salivary cortisols were sampled during their kind of computer time during the control. That's right. And then this slide shows the changes. We did look at chronic diurnal patterns and did not see a change over the course of the 12 weeks in this small study. But I'll make another comment to that in the next slide also. Good question though. This is a change in physical activity across the 12 weeks. So in other words, from baseline 0 to after 12 weeks of receiving 12 guided imagery sessions. And the black bar, again, is the guided imagery group, and they had a significant reduction in leisure sedentary activity. This is TV watching, video game playing, kind of couch potato activity, which was statistically significant versus the control group. We actually showed an increase across the 12 weeks, but the decrease in sedentary activity and the increase in moderate physical activity in the guided imagery group were significant, which allowed us to propose a larger study, which is now funded by NCAM. So this is an R01, and we're currently in the 2nd year of this study, and really just starting our first wave of intervention. We're about halfway through the first 12 weeks. So we're doing this in after-school programs now in high schools, in 4 high schools around LA County USC Medical Center in East LA. 1 high school is getting no intervention at all. 1 is getting the lifestyle class only, so again, healthy eating, increased physical activity. And then there are 2 guided imagery groups arms. One is getting stress reduction guided imagery only, so similar to what you just experienced, and the other is getting stress reduction plus behavioral guided imagery. So as I alluded to in our pilot study, we do guided imagery which promotes behavior change, increasing physical activity and eating more healthily. So it's a 12-week intervention. During after-school program, the kids come in. They get the guided imagery once a week, and then they get 2 lifestyle classes a week as well for 12 weeks. And then there's a 6-month maintenance period when they're going to get 1 class a month just to kind of boost what they've already learned. And then a 6-month period of no contact, and we're measuring outcomes at each of those periods. And our main outcomes are going to be dietary intake, physical activity, and changes in the cortisol daily pattern, as Dr. Friedman asked about. We think we were not powered to detect changes in that in the pilot study, which was, as all pilots are very small. But we hope we may see some changes in this study. So that's underway. Come back in 2 years or invite me back in 2 years. I'll give you the result.
And how long is the intervention?
It's a 12-week program and then once a month for 6 months. Yeah.
And these are non-diabetic.
These are obese. These are actually normal kids, obese and non-obese. And our outcomes our obesity outcomes and insulin resistance outcomes are secondary outcomes that we'll be looking at. But really our prime outcomes are, can we change health behaviors to a more healthy way of being using guided imagery? That's the primary objective.
And the guided imagery is some of what we did.
Mm-hmm. There's both that stress reduction element. So I don't know if I have an arrow here. Yeah. So one group gets only that for 12 weeks or variations on that theme, if you would. The other group gets about 4 weeks of the stress reduction. So they get a taste of it, but then we get into guided imagery, really targeting health behaviors and trying to motivate behavior change with the guided imagery.
Watching the video of people exercising or that, or?
They'll be experiencing imagery of themselves exercising or eating healthily, and then amplifying that response with the guided imagery. And then the idea being that when you're in an imagery experience, your body is experiencing as if you were actually doing it. And so as they experience that exercise or that healthy eating, then there are techniques within the imagery to help that carry forward into real life, basically. So I want to then now present the evidence base primarily in adult studies for patients actually with diabetes. And we'll look mostly at mindfulness-based studies here and then at yoga. So before 2007, there were not a lot of studies. However, those that were there did not show any adverse effects, first of all, first qualification in terms of phase 1 pilot studies, if you would. And most of them showed some effect on fasting glucose and A1C, and also on psychological outcomes. And you can see it was quite a variety of different interventions. These are mostly small studies. Some were well designed, however, but this is kind of just, kind of like just a little taste and saying, okay, we got to do some more work on this and really get, some well-powered studies to see if this is going to hold up. Back in that age, before the 2007, I think this was a study from 2002 here in the United States, and this was stress management using relaxation breath work, just like we just did, and plus a procedure called progressive muscle relaxation. And this was 50 to 60 adults with type 2 who either received stress management in the open circles or did not. They received just diabetes education in the closed circles. And after 1 year, this was a 6-month intervention, and the final outcomes were at 1 year. And they actually found a reduction of A1C by 0.5% that was statistically significant in the stress management group at 12 months. And 32% of the participants had a 1% or more decrease in A1C. And, of course, those of us in the diabetes field that know that that's comparable to what you get if you add another oral hypoglycemic agent on board to somebody with type 2 diabetes. So, again, this is a pilot study. This is not a pilot study. This was a randomized controlled study, but still relatively small. And what I find interesting in the study is that you see there were no differences at 6 months. And what the authors commented on is that the group that really showed the most reduction in A1C at 12 months were those who practiced the most at home and continued doing the relaxation exercises once they finished the initial 6 months of the study and then continued it over the long term. Now, I want to talk about mindfulness and mindfulness-based meditation because this is all the rage in the culture now. This is Time magazine from last year. And there have been over 500 publications now, as I mentioned before, on uses of mindfulness-based stress reduction in a variety of health conditions, and I'll show you some of the data in diabetes. John Kabat-Zinn really brought, is a physician in Boston, who really brought mindfulness-based meditation and stress reduction into the medical field and the health field. Mindfulness practices, as Zinn brought it in, is based on Buddhist meditation, but it's basically secularized. So it doesn't really consist of some of the Buddhist practices, but really brought it in such a way that it's a standardized program, that it can be repeated in a very standardized way, and therefore is an intervention that can really be tested in terms of health benefits. Because part of the problem with the early studies is that every intervention is different. And I'll show you data on yoga in a few slides, and that still suffers from that. What kind of yoga? For how long? What are they doing? You know, but Zinn's program really did a good service to the healthcare field in being a very standardized and clear dose of mindfulness. And I'll show you some of the data here. And this is his definition, basically, of mindfulness: paying attention on purpose, just like we just did, paying attention to your breathing on purpose. And being in the present moment, non-judgmentally. So as in our exercise, if thoughts come in, don't judge them, just kind of notice them and let them go again. So it's really about developing a lower reactivity to stress triggers. We can't prevent the stress in our lives, but we can change the way we respond to them. We can theoretically dampen down our autonomic nervous system and hypothalamic pituitary adrenal response to the stressors in our life, and then hopefully achieve health benefits by doing that. And just for those of you who like, really hardcore scientific outcomes, because a lot of the data I'll show you on diabetes is really clinical outcomes, of course, by necessity. But I just want to show you some basic science responses, outcome responses to mindfulness or meditation. This is a study by David Black, who's in preventive medicine at USC, and he did this study at UCLA. What's the matter?
Stupid boxes.
Oh, yeah. Okay, great.
One thing out also, if you can. Nope. Okay.
We'll go back to David's study, and I'll come back to that next one. So he looked at Alzheimer's family caregivers. Now, this is a population that's at high risk for stress, burnout. In other words, the family members who care for their family members with Alzheimer's. So it's quite a chronically stressed population, and they were randomized to either yogic meditation or relaxing music, which is nice, I mean, who wouldn't like that? But for 12 minutes a day, 8 weeks, all right? And then they looked at gene expression. And what they found was an increase in interferon response factors and a decrease in NF-kappa B, which is an inflammatory cytokine, in terms of gene expression, in favor of the yogic meditation versus relaxation music. So meditation can change gene expression. Well, that's pretty interesting. No, he did not look at that in this study. Yeah. The neuroscience field is also exploding with what are the effects of meditation. So this is just an example of one study showing that when you meditate, you activate your anterior cingulate gyrus and prefrontal cortex, and there's a bunch of different, the areas of your brain that you activate will be different depending on what type of meditation. Really interesting studies in the neuroscience field on this, and then if you change your brain activity, then that's got to have some physiologic and so effect. And so this is all being teased out. This is just kind of a teaser slide to show that these mind-body practices have physiologic and biologic effects, clearly. Now, what about diabetes? This is a pilot study in 2007 on the mindfulness-based stress reduction. So this is the John Kabat-Zinn program. It's an 8-week standardized program of mindfulness training. This was in 11 adults with type 2 A1Cs between 6.5 and 8.5, so pretty well controlled actually population. None of them were on insulin. And they took the 8-week MBSR program and then had follow-up a month later, showed 0.5% reduction in their A1C. The effect size of 0.88 shown there is actually a pretty large effect, so that would suggest that this is not only statistically significant, but may have clinical benefit. Lower blood pressure and lower depression, anxiety, and psychological distress scores. Okay, obviously, small study, non-controlled. All right, let's see more. In Germany, a study looking at diabetes and stress, 110 adults with type 2. Again, 8-week MBSR study on these patients, and they did have a control group in this study. And 1 year after the program, they did follow-up, looked at follow-up results. So again, an 8-week program, a single 6-month booster class, and then measured outcomes of the year. Showed overall improvement in mental health, depression, stress, diastolic blood pressure. Did not see a change in this group in terms of glycemic control. Another study using mindfulness-based cognitive therapy. So this is similar to MBSR, but also adds some cognitive psychotherapy in the mix. And they looked at this versus treatment as usual. So not getting any kind of mind-body or psychological intervention. This is from the Netherlands, this study. They had a mixed group of type 1 and type 2, about half of each. And this patient population they chose specifically because they already had low levels of emotional well-being based on a World Health Organization score on emotional well-being. And they looked at their scores at the end of the 8-week program, seeing lower perception of stress, lower stress, lower depression, lower anxiety, and improved quality of life, health-related quality of life. Again, no effect on glycemic control, however, in this group. These are just some of their figures from this study published in Diabetes Care just a couple years ago. Lower depression score, lower anxiety, lower perceived stress, the MBCT group there in the top line going from 19 pre-study to 14. The treatment as usual from 20 to 19.6. That was highly statistically significant. Quality of life increase, MBCT 33.9 to 42.9 versus the treatment as usual group. These were significant findings, p-value less than 0.01. And hemoglobin A1C, again, not a significant between group difference, but they pointed out in this study the starting A1C was 7.5 in one group and 7.6 in the other group. So not a lot of room to perhaps improve. You may get different results if you have a more poorly controlled group to begin with. 6-month follow-up. So after the 8-week program, the data I just showed you were immediately after the 8-week program. So what happens at 6 months with only a single booster class at 3 months? They show sustained effectiveness in terms of stress reduction, depression, anxiety, and diabetes-related distress, but no change in A1C even at the long term. So, oh, I'm sorry, one more. I thought we were at the summary slide. This is, again, mindfulness-based cognitive therapy versus cognitive behavioral therapy, which is a well-established evidence-based psychotherapeutic approach to folks with diabetes and has been shown to be successful, versus a third arm of wait-listed control. All right, so what they found was that, the mind-body cognitive therapy group consisted of formal meditation, some yoga practice, and informal daily mindfulness practices. At the completion of the study, they found that mindfulness-based cognitive therapy was equal to the kind of gold standard psychotherapeutic approach in people with diabetes, the cognitive behavioral therapy, in decreasing depression, anxiety, improving well-being, and improving diabetes distress. Again, no effect on A1C, however. So if we were to summarize these mindfulness-based intervention, we see sustained improvements in negative psychologic states and improvements in well-being in response to mindfulness training. We see that it can be a viable alternative to cognitive behavioral therapy and perhaps to other psychotherapeutic approaches, but the role on improving glycemic control remains unproven at this point. Obviously, more work is needed and more studies. I want to show you a few slides now on yoga as a mind-body intervention. It obviously has been used for centuries in India as a standard mindfulness-based and spiritual-based practice. In this country, we think of yoga in terms of posture yoga. There are a lot of other potential elements to it, but for the most part, that's what we're talking about. We're talking about yoga interventions. It has low cardiovascular demands and low impact, so it's pretty good for patients, for instance, with obesity or cardiovascular disease or disease risk. This is just a case narrative, just to kind of whet our appetite. A 22-year-old college or graduate student, type 1, poor self-care, even though she's got an insulin pump, but something scared her recently. She's been hospitalized a couple times, and seeing an integrative psychologist, she began to do yoga breath work on her own. And at one point, while in the psychologist's office, her glucose was 250, and they said, well, let's just see what happens if we just do yoga for 15, 20 minutes. And they did that. And her glucose came down to 200, and she could not account that to a bolus recently on her pump. She hadn't had a recent bolus. So a very cute anecdote, but now this woman's doing yoga 3 times a week, reports that her anxiety is down, feels more hopeful overall, so perhaps a wellness effect, and curiously is needing a lower basal rate on her insulin pump. That's an interesting outcome and makes one wonder if her stress hormones that tend to drive insulin resistance are lower, perhaps, and so she needs less insulin to maintain her glucose control at a basal level. So a few studies in yoga. This is 60 adults with type 2, randomized to yoga, which is based in asana yoga is the postures, and I'm not a yoga practitioner. I think pranayama yoga is breath work. Does anyone know here? No? No yoga people here? Okay. The control group got diabetes education, all right? Typical diabetes study control group. And what they found was a reduction in A1C of 0.8% in the yoga group, reduced fasting blood glucose, and improvement in lipids. A review in 2010 of yoga studies, a systematic review. Now, this is interesting because this only reviewed studies up to 2007. So the paper came out in 2010, and there actually weren't that many good studies that they could find. They only found 5 studies that really reached criteria of being well-designed enough and randomized, or that they could really review the outcomes and make some conclusions. So they did see in this population, however, improvements in glycemia and lipids. The studies that they did review were well designed, although they did notice blinding bias. Now, this is one of the problems with complementary alternative modalities, is that you cannot double blind. I mean, the subjects know if they're doing yoga or not. And the investigators want them to know, of course, and the investigators often know and don't take appropriate steps. What needs to happen is that those who are interpreting the data or analyzing the data should be blinded to the group, but often they're not. And so there still is some study design work. I know in my study that I showed you that we're doing now, the R01 with 4 arms, I had to jump through many hoops with NCAM to convince them that the people doing our measurements, our outcome measures, and our data analyses would be totally blinded to group, because you never know where some subtle bias might actually influence the measures you're doing. So, all right, conclusion after this paper is obviously more yoga studies needed. Well, here's a meta-analysis, 32 very well designed. So this is 2014. So what we're seeing is an exponential increase in mind-body literature coming out in the evidence base. So this is almost 3,000 adults now participating in a variety of yoga interventions. Now you see with these meta-analyses, there's a variety of different participant types or subjects here. Some are healthy, some have diabetes, some have coronary artery disease. And so it's a little bit hard to interpret all this, but we can tease out some diabetes-related outcomes here. So first of all, versus non-exercise control, they saw improvements in BMI, blood pressure, and lipids. However, they did not see differences in the subgroup of these studies where it was yoga versus exercise controls. So perhaps what they're seeing here with the yoga is the exercise or physical activity-related aspects of the yoga, of the physical postures. Now, in a subset of patients that had either type 2 diabetes or coronary artery disease, so within this overall meta-analysis, they did find if they added yoga to their medications, to their Western-based therapies, they saw improvements in BMI, lipids, blood pressure, and A1C that were significant. So that's good to know, and gives us some confidence perhaps that if you have a patient who can't keep with an exercise program, but maybe they're interested in yoga, there's an evidence base to support that might help them. Okay, coming towards the home stretch on the talk here now, I want to just offer a few other morsels to consider as possible integrative approaches to diabetes. And I'm going to bring up the possible role of community as healer, of narrative medicine, or in other words, listening to the patient's story as helping to heal the patients and hopefully improve their diabetes balance. And finally, a last slide, the possible role of using nature. And I'll present some data on the pilot study that I did with a medical student recently on perhaps the role of wilderness as healer and teacher. So what about community and the role of perhaps shared medical appointments? And I know this is a topic that's near and dear to Dr. Friedman's heart, because I know you do shared medical obesity visits here at Drew and Martin Luther King. So there have been shared medical appointments. There's literature in diabetes, and they have shown in some mixed results in adults with type 2, often with comorbid conditions. Like the other mind-body studies, the studies with shared medical visits, the interventions are kind of all over the map for how long did they meet, how many people in each group, et cetera, et cetera. So it's hard to draw some conclusions. There are some results indicating that group visits might be useful in adolescents with type 1. And in fact, I'm about to initiate shared medical appointments in my diabetes clinic at LA County, USC for adolescents. And in fact, as I'm asking them if they'd be interested in participating, I'm actually getting a very enthusiastic response that they really want to be in group visits with their peers and see that might benefit them. However, long-term studies are lacking there. This is just one study in adults with type 2 showing that over 2 years of group medical visits, the group receiving group medical visits in the dark diamonds below maintain their A1C in target range, whereas the other group kind of had an upward drift over 2 years who just received kind of treatment as usual and diabetes education. So community, group interactions. Now what about narrative medicine, or as I call here, the power of story? This is a quote from Louis Mel Madrona, who's a family doc and also boarded in psychiatry. Also happens to be a Native American physician and uses indigenous Native American practices in his healing work. He's written a number of very interesting books, and if you're interested in any of those areas, you might want to check out either his book entitled Narrative Medicine, or if you're interested in indigenous medicine systems, coyote medicine. But Lewis says each person is unique and must be approached individually to discover how he will heal, or she. No two people with the same diagnosis are narratively alike. So this is alluding to what I started with, the difference between disease and healing. So no two people with diabetes are the same and can really be approached the same way to heal. You wouldn't expect it. The role of diabetes in their life is going to be very different. So it's important to hear their story and hear what's going on so that you can figure out what to do. I'll show you a couple case vignettes about this when we close. So this is a pilot study that we did a couple years ago, trying out a group intervention which used both the community, the group, as healer, as I mentioned, and also narrative practices. So we call this council, or Diabetes Empowerment Council. Council is a facilitated group process based actually on primarily indigenous practices, whether Native American, African, or others, but actually other groups use this as well. Quaker meetings have a similar process. The basic thing that's going on here is you see us sitting in a circle. So members sit in a circle, so there's no hierarchy of expert and those being experted upon, if you would. Everybody's equal in the circle. We use a talking piece. It can be a stone or a feather or a pen. What that means is that whoever holds the talking piece is empowered to speak, and everyone else is empowered to listen. So it really lends itself to very deep communication because it eliminates small talk, cross-talk, that sort of stuff. So people are encouraged to speak really what's in their heart and to listen from the heart, so really listen to what's being said. And we used a real smorgasbord, if you would, of integrative modalities in this council intervention with these, this was with young adults with type 1 diabetes. So we used the stress reduction guided imagery, just as you experienced earlier. Narrative storytelling, we would have them tell their personal stories of their diabetes. How was their diagnosis? What was that day like? What's it like to check blood sugars? What problems and issues do they have? And the young people basically learned from each other through this. And we also used mythic storytelling where a fairy tale or a mythic story can actually provide archetypes for them to tie into their lives. It really is telling the story of a life journey, and the people could relate their own lives to that story and say, oh, I would do that just like that character in the story. We had discussion topics that were either diabetes specific or life in general, really whatever the young people wanted to talk about. And just to go through quickly, we had qualitative results. This manuscript is in preparation, by the way. We presented this at the ADA a couple years ago. Very high program acceptability, and the members really indicated that they liked the increased feeling of relatedness. And I should say that by self-determination theory, which is one theory of behavior change, really emphasizes relatedness or group cohesiveness as being a motivator of health behavior change. So the group really liked the experience, and they showed a reduction after 12 of these council sessions in perceived stress, which was significant. And of interest, although there was not a significant reduction in A1C, the change in A1C across the 12 intervention sessions was related to the change in perception of stress. So if they felt the stress in their lives was reduced, they actually had lower A1Cs. Those were significantly related. So that's very intriguing. And as soon as I get this published, I'm going to be putting in a grant to hopefully follow up on this with a larger intervention. I'm going to have to skip this slide for the sake of time, I think. Well, maybe I can't because it explains that slide. Basically, shorthand version, based on the qualitative data we got from the focus groups, this is a little bit of a complex slide, but if you see here, this is what we think is happening. These are the council sessions, each of these red dots. And we think that the youth are learning things, whether it's guided imagery or maybe from a story of one of their peers, how to handle high sugars at night or something like that. They learned something. And then they take it out into their life. What happened to my arrow? Take it out into their real life, and they come back and they learn it again. And then they start making changes in their real life. Maybe they start using guided imagery, or maybe they start changing their insulin dosing the way they heard their peer do it. And then they reinforce it, and then they do it some more. So they're in this kind of field of health behavior, if you would, which ultimately leads to change. And what we think are the active ingredients here of the Diabetes Empowerment Council are promoting their autonomy, so really motivating them that they are the actors in their lives, reducing stress, so all the benefits that can have, and increasing their relatedness and their learning from each other, so the role of community in healing. And we think this is leading to an acceptance or an integration of diabetes into their life, so they're not fighting their disease anymore. Improvement in their own relationships with those around them, and actually motivating internal desire for change in what's going on. And that this would lead to new activities and behaviors, and hopefully, I left an arrow out, but better diabetes control ultimately. So this is a theory that we came up with from our qualitative data that then we hope to prove in future studies. So look at this spiral here. This makes me think of quantum field theory, of course. Now, are there any physicists in the audience here? Good, I won't be in trouble, because I don't know much about quantum field theory, but I did hear a talk from somebody who does know about it and how it might relate to health behaviors, all right? And here's how it goes. You see these fields, these quantum fields. So imagine that this quantum field is somebody with, oh, I gotta move that so you can see what we're talking about here. It's always in the way. Imagine this is a field of somebody who is doing poor diabetes self-care and has a really high A1C. So this field, these little dots and nodes here might consist of skipping insulin, or not testing very much, or not carb counting, or not paying attention to anything in terms of their diabetes care. And then something happens in quantum field theory that changes one from one field into another. There's some event. Sometimes you know what it is, sometimes you don't. So here I'm showing that as a lightning bolt out of the blue, right? And so what happens here is that the person goes from poor self-care to good self-care. This is not a linear process. In Western medicine, we think everything should go linear. You give them 8 sessions of MBSR, and they should change in 8 weeks. I give kids 12 sessions of healthy lifestyle, and they should be healthier lifestyle. It might not work like that. They might not change for years. They might not shift into this other field. These young adults we did the counsel with, maybe they didn't improve their A1C yet. Maybe they didn't change their stuff yet. But eventually, something might shift them into this field where they do things differently, and things do improve. I have some anecdotal clinical evidence of this, or if you want to call it evidence, anecdotes, patients that I think. So here's a couple, just for your consideration and just to promote some thought. Miguel, a 19-year-old college student, really apathetic over the years about his diabetes. Really knew what to do, but didn't want to do it, right? We have a lot of young people like this, very poorly controlled with a high A1C. Every time we talked about things that interested him, as well as changing his insulin, encouraging him to test more often, all the stuff we do as endocrinologists. Now, in the last 6 months, something's changed. He's testing his glucose more often. His A1C is now down to target. And I asked him what's going on, and he said, I just decided to care. Now, I don't know what that means. What made him decide to care all of a sudden? Just a maturational process? What was the lightning bolt, in other words, from the previous slide? And when did it strike? Maybe he heard something in clinic 3 years ago, and now he heard something else from somebody else, and it went, oh yeah, that's what my doctor was talking about then. Okay, boom, he's in another quantum field, and his diabetes is totally different. Oops, it doesn't want to advance. Okay. All right. I was told to do a case vignette that you can answer a question on. So this is really a softball, so don't be worried. You're seeing, and this is a true case in my practice, you're seeing a 19-year-old young woman followed for years with really horribly controlled diabetes. She's persistently, quote-unquote, non-compliant with checking her sugars. No doubt it omits insulin, although she won't admit to it. She's a person who seems to be, she's really emotional, and yet she keeps her emotions bottled up and won't talk about them. She really shows poor insight into them. She's always evasive in clinic about talking about how often she's testing or taking her insulin, that sort of thing. And her last A1C was in the stratosphere, and it's been in that range for quite some time. So after hearing today's talk, here's the softball for you. And assuming you had all the resources at your disposal that you could have, what might you consider as your next approach? Doing what we often do, increasing her insulin dose and warning her about the risks of poor control in terms of kidney failure and blindness. How many of us have done that? Scold her for being non-compliant and not listening to your expert recommendations and storm out of the room. Well, I know certainly any of us who deal with diabetes have felt that way and wanted to do that, whether we do it or not. It's not usually productive, basically, but we certainly felt that. Suggest she try an insulin pump. The data certainly has shown that if anyone who's going on a pump really needs to have the behaviors that they can control their diabetes without a pump, actually, first. An insulin pump is no panacea. Or if you had the opportunity to refer her to a center for integrative medicine where she could learn mindfulness techniques and speak to an integrative psychologist, who would do that? Oh, okay. I see a few hands. All right. Well, for this case vignette, that's the correct answer. All right. I don't have an integrative center like that. We're trying to get one going at USC, actually. But here's what I did do with this girl. I did invite her, and we did 2 30-minute sessions just to talk about her life, not to talk about diabetes at all. She told me about her college, about movies she likes, about her family, about her dog. And we did not talk about diabetes, as I said. I taught her some simple stress reduction guided imagery and suggested she do it at home. The next 6 months, she's practicing her breathing and her imagery occasionally, And I did note that she's testing a little bit more, 1.5 times a day instead of 0 point something. Her A1C was 12.8. Is that significantly better than 14.2? Well, it's better. Is it sustainable? I don't know. It's obviously not goal. Now, I just saw her last week, and she was very tearful and upset, had some significant stressor in her life, losing both grandfathers within the last 4 months, and losing her mother, her primary confidant, to talk to about it because her mother is in her own grief process, at least losing her father. Her A1C is back up to 14, but I did note she's still testing 1.5 times a day. So questions to consider. Did the imagery that she did or the stress reduction, is it not working? Or is she just still stuck in that same field, that same quantum field of her diabetes, and the lightning bolt really hasn't hit yet? But perhaps she's on a healing path. She is testing more. There is some forward motion. So I haven't lost hope, certainly in her case. And just to close out, one last slide after this, I've been real interested in the role of nature as a possible intervention. And if you call it a mind-body, certainly a whole-body intervention. In 1999, I took a bunch of type 1 diabetic adolescents up in the Trinity River, and we did a canoe trip. So experiencing nature, community, we did some storytelling around the fire at night there. You see us in council. Diabetes discussions again. In fact, these two guys in this canoe there that you see, about 10 seconds after this picture, hit the stone wall that's right in front of them. They did not turn the canoe around the bend in the river, and they capsized. And so they were okay. We all pulled off on the gravel and talked about how sometimes in their life they hit the brick wall in terms of their diabetes care. And so use the experience in the canoe as a metaphor for what they do. Now this is a study, I was talking to Dr. Hara over here about Ali Arastu, who was a medical student when we did this study, and now is a pediatric intern at Children's Hospital. So we looked at the role, oh, I can't move that one, of effects, it says effects of wilderness camp in urban school students. Okay, and what we did was, Ali actually did this. He took a class of high school students from an urban high school up to the Golden Trout Wilderness Camp, which is up in the southern Sierras. So they did a lot of hiking. They did counsel twice a day, just as I described to you before, that circle, talking circle. They learned how to cook some foods in the wilderness. And they did yoga every day. Here they are doing downward dog pose. I think that's what that is. And then he measured outcomes. And baseline measures versus post-wilderness measures. Oh, I'm sorry, I skipped. They did have a classroom intervention for an after-school class for 12 weeks where they were taught good, healthy eating and physical activity, promoting lifestyle skills. But our main outcomes were, and then after that 12 weeks, then they went out in the wilderness a few weeks later for a 1-week wilderness experience. And then we measured these outcomes post-wilderness about a month after they were up in the camp. And what we saw was a reduction in perceived stress, highly significant, improvements in measures of well-being, self-esteem, general well-being, and life satisfaction. Dramatic improvement in group cohesion. The group cohesion scale, it's better if your score goes down. Going down means more group cohesion. So, and what's interesting here is that you see that between baseline and the end of the after-school class, they did not improve their group cohesion, whereas the wilderness experience really did improve their group cohesion significantly. And then in terms of eating behaviors, they drank about half a cup of sugary beverages less a day after the intervention, and rated their own eating habits as much improved after the intervention. So again, this is preliminary. This is a pilot study. This is no control group. But Ali and I are still working at this, and we want to take a lot of more kids out into nature and see what can be done with these interventions. So all of these kind of new ways of thinking about approaching diabetes, I want to leave us with one more quote from Professor Einstein here, that the significant problems we have, and I would propose that the obesity epidemic and diabetes represent significant health problems of our time, cannot be solved at the same level of thinking with which we created them. How did we create them? Well, Burger King's, sugary, subsidizing sodas, et cetera, perhaps played a role, and perhaps our stressful environment. So let's think outside the box, and that's what some of these modalities are doing. So I thank you for your attention. If there's time for questions, I'd be happy to answer.
Let me try to unmute the audience. Here. Mm-hmm. Do that. And we can start with questions in the room here. Okay, anybody in the audience want to ask questions? I think I unmuted everybody. Yes. Good. Yeah. Right. And maybe repeat the question. Yeah. Oh, okay. Let me just ask, I'll repeat your question, but just so I'm clear, are you referring to the case vignette I presented or my plan to do shared medical visits? I'm talking about the vignette. Okay. So the question is, do we devote full clinic time for just that kind of a visit? Given what is happening in medicine, and you have to do this all within it. I consider that we have to think about the way we deliver medical care. And it's really a problematic thing, I think, how we as physicians and healers or care providers and healers are being forced into models that really are not taking into account what is needed for a healing visit. They're obviously being driven by economics, So this is really, I see these as really, Western-based, economy-based models, which many times don't do the patient a good service. It's very hard to do these. That young woman that I mentioned, yes, I called her in and vital signs done. She got her blood pressure measured by the nurses. And my physical exam consisted of generally looks well and no acute distress, and spent the rest of the time health counseling, basically. And with the group visits, and Dr. Friedman might want to speak to this, you can actually see many patients over a longer period of time within a group encounter and still be able to write individual progress notes on those patients and be able to bill within the current constraints of the system. I don't know if you have a comment about that. Yeah, I have a sort of related question, but I think the group visit has that power of the group, and you can see, we try to see 20 patients, and now we're trying to enter their on ORCID. I have a brief note on it, but I think there's a lot of advantages of a group. The follow-up question to Christina's question. So, how do we as providers in DHS, how do we incorporate some of your suggestions? Should we have an integrated clinic, or should we try to do it within our 15-minute visits? Or, I think you're right. These things work, but as Christina said, how do we build this into our short visit time?
Really good question. Really good question. I can describe kind of what I do sometimes, occasionally, and actually I just had an encounter this morning. I could have included her vignette. I'll schedule that 20-minute visit for an individual, essentially mind-body session, if you want. Again, her physical exam consists of vital signs stable, well-hydrated, no acute distress, And the discussion with her today, this is really interesting. She's another one of these adolescents with just out-of-control A1Cs, right? And particularly, she would go to bed and her sugar would be 240, and she'd wake up and it would be 400, 500. And I couldn't figure out what was going on. I kept going up on her Lantus, She looked me straight in the eye and said, yes, I'm taking every dose. Yes, I'm taking every dose. Okay. Finally, I got to, just tell me your story. What do you think's going on? I stopped trying to figure it out.
Go on.
So what's going on? She wakes up almost every night and goes in the kitchen and eats and doesn't take insulin. And, you know, I probably should have been smart enough to think of that, but I wasn't, you know. So what I did was, from last month to this month, I said, okay, why don't you journal every time you do that? And just become aware of why you're doing that. So she comes in this morning, well, what's going on? Oh, I'm doing better. I'm only doing it twice a week instead of every night. Oh, that's cool. So what we did today was I did a quick little guided imagery with her. I'd already done some stress reduction imagery with her. And what she's going to do now is when she wakes up at night, before she gets out of bed and goes to the kitchen, she's going to close her eyes and imagine herself going to the kitchen and eating. And I said, see if that replaces the need to go to the kitchen. Because sometimes what we do in our imagery, really we experience as a whole body. I think I mentioned that earlier. So I think there are practices here where you can learn a quick hit, you know, do a 2 or 3 minute exercise, and I've done that a lot with my patients in that 20-minute. You know, here's a way to relax.
Do it, you know? Of an exercise or something like that?
I don't, but that's a good idea.
Can you make one and send it to us?
Yeah, I'd love to. Thank you. That'd be great. That'd be great. Yeah, I like that idea. And then I think, you know, I think there is a role for integrative centers where a little more work can be done. We're trying to develop one.
So I wanted to answer Christina's question in terms of the CME question, and in terms of your case. I think the other answer that Dr. Fisher was their keynote speaker diabetes day, several of you guys were at, put is bounce it back to the patient. Don't try to lecture them. Ask, what do you think is the problem? You know, you have that person with A1C of 14, and she says, well, I'm eating at night all the time, you know? So sometimes they'll give you insight. So I think that's a crucial thing I learned in diabetes. It's fascinating.
Yes, exactly.
So one proposal I have, I really like you to start this group visit, is to do your group visit sort of for the patients, these out-of-control patients that need this, the group approach, but also this mind-body approach. If you have, you can do this mind-body approach for 20 people in the room as easy as one, basically. Maybe it's better than everybody else over the back and be mellow and stuff like that. So almost that maybe we can have this as a referral place for the whole county, maybe a separate one for type 1s versus type 2s, and you know, Janina at the wellness, the Memorial Center, the wellness.
Absolutely, yeah.
So maybe we could do it in conjunction with her there. But I think that to have to try to build it into your practice in your clinic, maybe do something 2 minutes is okay. Yeah. But if we can have a place, we have these out of control stress patients, we can sort of send them to.
Sounds great.
Sounds good.
I love that idea.
And do you think so? Could your clinic take some of the pediatrics patients from all over the once you get up and running? Or
I think I would love to do that. That would be fantastic. Yeah, let's talk more about that. That's a great idea, Theodore.
And Christina's going to try to start a group visit for clinic in Venice, right?
Oh.
Okay.
Fantastic. All right, good.
Any other questions from here, from the audience? Okay, thank you so much.
Thank you very much.
Great. Can you turn this off? Well,
Okay.